Hello students, I am the OGGuru Dr. Punit Bhojani here with a single point agenda to make OBGY your most favorite subject, most scoring subject, very important video, frequently asked MCQs in OBGY along with very important and expected MCQs. We are going to discuss today. Feel free to get in touch with me on phone and WhatsApp on this number and download the OGGuru app. And I am coming up with a OBGY rank booster course. It's just 6 hours. 3 sessions we are going to do starting from 13th, 14th and 15th August, 2 hours each. Whichever source OBGY you have studied from, don't worry. This 6 hours is going to boost up your preparation and boost up your rank. And just in 333 early bird offer is that download the OGGuru app. We are going to discuss all the image based and video based questions in one session. Clinical MCQs and most expected MCQs along with the notes will also be there. So just in 333 attend these 3 sessions which will be totally 6 hours, 2 hours each into 3 sessions, and OBGY will become your highest scoring subject in the upcoming NEETPG examination. More about this later on. Now let us begin with this. Now please keep a practice of reading this long MCQs because longer kind of questions are going to come. And if you see lot of extra information, sometimes it just helps to read the stem, the last part of the MCQ first. Okay, but if you see over here, so okay, we have got a 32-year-old lady, 34 weeks gestation, being followed up for hypertension. Blood pressure is this. Labetalol chalu hai, symphysphenolide 2 cm less. All this is, see, some extra information. It may or may not be relevant. NST was performed. Okay, NST was performed and NST is non-reactive even after 20 minutes. So this gives you one more indication. Okay, one more MCQ. Okay, what is the next step to be done if the NST is non-reactive? Okay, so the question over here is, please understand this. Okay, whenever there is non, so NST we don't say the word normal and abnormal, we say either reactive or non-reactive. And if the NST is non-reactive, the next step, remember my dear student, is to do a BPP. Is this understood? So that is done also. Okay, so since the NST is non-reactive, a BPP is further done as a part of antenatal surveillance. Now, all are components of BPP except. So, if you see, my dear students, one-liner question has been made into 6-line question. If you see, this whole thing extra is just time pass. It has got no relevance with the last part. So it is just given to waste your time. Yes, exam such questions can come. Many times when we will see also starting the question starts and ending all are interconnected and everything is important information. Now here let it be 34 weeks, let it be 35 weeks, not important, let it be blood pressure, whatever, that is not the question. The question is simple one-liner. The question actually starts from here. Okay, all are. So all this, as I said, is just extra time pass information, time pass or time waste, I would say. So all are components of BPP except 1, 2, 3, 4. Is it clear to all of you? So now please understand this. How is the BPP done and what is BPP and what is it called? Okay, so BPP, my dear student, it is called as biophysical profile. And how is it done? And it is called as whose criteria? Yes, it is called as the Manning score. Very important. Now totally there are 5 components and each component we either give a score of 2 or 0. So just remember this. By the way, also if they ask you one more MCQ, okay, what is the maximum score of BPP? So sir, the maximum score of BPP for any patient can be 10 by 10. 10 by 10 matlab baby is takatak, perfect, 10 by 10. 8 by 10 slight problem, 6 by 10 more problem, 4 by 10 severe problem. So what does this BPP tell you? Sir, BPP tells you in when to deliver and how to deliver. Why? Because sir, suppose this score is becoming less, then it is danger. The baby is telling you, okay, get me out. Okay, so when the score is less, 4 by 10, 2 by 10, you do immediately deliver. Okay, do a C-section or induce labor and get the baby out. In fact, if the score is very less, 2, 4, then we can directly do C-section also. Okay, so as the BPP score is decreasing, it indicates basically fetal distress, fetal hypoxia. Okay, now what are the components of BPP? And can you tell me in BPP who will count the fetal movement? One of the component is fetal movement. And who will count the fetal movement? Kaun count karega fetal movement? Anybody? Mother, if I give you option, mother, father, intern or the neighbor. Anybody? Who will count the fetal movement in BPP? Mother, no. Father, no. Intern. Intern has to study for the NEET PG and for other exams. He's got a lot of work to do. Intern does not have time. Neighbor. Why is that? If the neighbor is counting the fetal movement, there's a lot of problem. Okay. So please understand this. And the common answer I get is that, sir, mother will count the fetal movement for BPP. And that is the mistake. And that is clean, bold and wrong. Please understand this. Okay, sir, when it is BPP, mother will count the fetal movement. That is different. When it is BPP, in BPP, sir, we require ultrasonography. Ultrasonography has to be done for 30 minutes. And NST is a part of it also, BPP. So remember this. Okay, totally there are 5 components. NST is component number 1 and component 2, 3, 4, 5 is done using ultrasonography for 30 minutes. The fetal tone, the fetal movements, the fetal breathing movements and the amniotic fluid. Okay, so please understand this, that in BPP a sonologist will count the fetal movements on the sonography screen. In 30 minutes there should be 3 movements. Tone ke liye there should be the baby is flexed, so extension and return back to flexion, or opening or closing of the hands. This detail is not expected at your level, but please understand this, okay, when the mother counts the fetal movement. So then what is where mother is counting fetal movement? Yes, when the mother counts the fetal movement, that is called as FKC, fetal kick count, which the mother will count. And there is a technical difference between this fetal movement and fetal kick count. Is this understood to all of you? Clap if you have learned something new. Thoko tali. So this is a simple MCQ, but based on the technicality, okay, sir, fetal movement and fetal kick count are not the same. Sir, in BPP, fetal tone we do, NST we do, amniotic fluid we do, but we don't do fetal kick count, sir. Fetal kick count is what the mother counts at home. The fetal kick count is counted by the mother. In BPP, we have fetal movement. Is this understood to all of you? There is fetal movement and fetal breathing movement. So is this understood to all of you? And that's our answer, sir. NST, fetal breathing, fetal movement. Okay, make sure fetal movement, and please write down, and not, it is not fetal kick count. Okay, fetal kick count is different. This is BPP Manning score. You can see 1, 2, 3, 4, 5. Is this clear to all of you? And please comment in the chat box to save time, because you can see this NST I have to do for first 20 minutes, and then remaining thing ultrasonography has to be done for 30 minutes. So totally 50 minutes it will take. So for shortcut, there's something called as modified BPP. Very simple MCQ. Please comment in the chat box, what is modified BPP? Is it clear to save time? Because modified BPP, we look at only 2 things. Okay, so what is modified BPP? Please comment in the chat box, and I hope you have got this answer correct. It is this, all this is extra information just given to waste your time. Question यहाँ से शुरू होता है. All are components of BPP except answer, sir, fetal kick count. Why? Because in BPP it is fetal movements which I see on sonography screen. Fetal kick count is separate, which the mother counts at home. Okay, and not the neighbor. Neighbor is not counting, nor the intern. Intern has to study for the NEET PG and other exams. Okay, is it clear? So now moving on to the next MCQ, which is yes. Now please pay attention over here. Very, very important. This was again asked in the previous and again longest question. Please understand this. So now over here in this question, as you will see, everything is important. There's nothing like every line is important, every word is important. Okay. So 22-year-old lady, missed periods, fine. Comes to OPD with history of bleeding PV, pulse BP, okay. Bimanual examination reveals a soft uterus, no tenderness, no adnexal mass, mild bleeding, HCG values are given to you, and ultrasound reveals empty uterus. So what directly student think? Okay, sir, beta HCG is positive and ultrasonography, the uterus is empty. And therefore, everybody will think only of ectopic pregnancy, isn't it? Most of the time, yes, yes. And therefore, everybody will think in terms of ectopic pregnancy. Okay, do for immediate surgery. Okay, wrong. Go for methotrexate. Wrong. Why wrong? I will tell you. Because please understand this. This is your not only confirmed ectopic. This is not confirmed ectopic. Why? Please understand this. It's a very important and tough MCQ. Because, sir, the uterus is okay, no adnexial mass. no adnexial mass on examination also. And when the beta HCG is positive, even empty uterus, and both adnexia are normal. Is this understood? So it is not yet confirmed ectopic. This is not yet. We have not yet confirmed. Is this clear to all of you? Basically, the diagnosis is not yet confirmed. It is pregnancy of unknown location, PUL. Pregnancy of unknown location. That means that it could be inside the uterus also. It could be ectopic also. When do I consider it ectopic? Please understand this. For ectopic pregnancy, yes, the beta HCG positive, very good. Uterus empty on sonography, very good. To make the MCQ tougher, they will say instead of the uterus empty, they will say uterus ke andar pseudo sac is seen. The radiology teacher will guide you, explain to you. Pseudo sac is seen also can be told to you. Pseudo sac is same as uterus empty, but along with it, they will say, okay, sir, there is a adnexial mass outside the uterus. Okay, so please understand this, okay, when the uterus is empty, we are supposed to look outside the uterus, left side, right side, and suppose if they say, okay, sir, we are seeing a adnexial mass, yes, then it is ectopic. Is it clear to all of you? So please understand this, that for ectopic pregnancy, beta HCG positive definitely, uterus empty, yes, but adnexial mass also has to be seen, and then we decide whether the patient is stable, unstable, ruptured, unruptured, and go for methotrexate. There are various criteria for methotrexate also. Okay, you can comment in the chat box 1 or 2 criteria and the size criteria at least. Okay, how much is the adnexial mass? If the adnexial mass is suppose say 2-3 centimeter, then can I give methotrexate? Yes. If the adnexial mass is 5-6 centimeter, methotrexate will not work. Okay, so the size criteria, gestational sac criteria. So for ectopic pregnancy, remember my dear students, for ectopic pregnancy, yes, beta HCG should be positive, uterus empty or pseudosac, but along with it adnexial mass. Okay, some mass outside the uterus, but this is not the case over here. Here, sir, even on examination, by an examination, no adnexial mass seen, and along with it on sonography also empty uterus. So they are leading you towards ectopic, but end mein googly ke both adnexia are normal. So now what will you do? Now please understand this, okay, directly I do not do a surgery, and directly I cannot go ahead and give methotrexate. Yes. Now please understand this, I can repeat scan. I can repeat scan. Okay, sir, suppose this scan I am not seeing anything, I can repeat scan after 6-7 days. Yes, but during those 6-7 days, if it's ectopic, the ectopic can rupture. And therefore here I make use of my logic or the funda. What is the funda? Okay, sir, when it's a pregnancy of unknown location, it could be a intrauterine pregnancy versus a ectopic pregnancy. And how do I know it? Yes, sir, which is the answer. Okay, sir, repeat beta HCG after 48 hours, and then the the mystery will open up. Ras khul jayega. Kya ras khulega? Okay, sir, when I repeat, that's the answer. Okay, when I repeat the beta HCG after 48 hours, what will happen? Yes, sir. In a early intrauterine pregnancy, we know that beta HCG doubles. Beta HCG doubles every 48 hours, and that's the reason why we repeat after 48 hours. Okay, from the same laboratory it should be done. So suppose this is 1000, example, this is 1000, the HCG is 1000, and after 48 hours, if the value comes out to be 2000, yes, then I am dealing with a intrauterine pregnancy. Is it understood to all of you? An ectopic pregnancy, since it's a defective pregnancy, yes, the HCG will increase, but it will not double. Okay, and very difficult virgin MCQ, and comment there was something that's called as Cadder's rule. Cadder's rule. What is the Cadder's rule? Okay, so please understand that in ectopic pregnancy, HCG will increase, yes, but but because ectopic is a defective pregnancy, HCG will increase, but it will not double. Keep this in mind. So यहाँ पे क्या होगा? Example same. So this 1000, this will come out to be 1200 or 1300. Then I know okay, I am dealing. This is just an example. Okay, this is just an example. It will become 1200, 1300, 1400 like that. So it is not doubled. Is it clear? Here, sir, 1000 became 2000. So HCG has doubled. Is this clear to all of you? So if HCG doubles every 48 hours, we are dealing with an intrauterine pregnancy. If the HCG does not double, then you are dealing with ectopic pregnancy. And for the next best step to be done, is it clear? So this is the diagnosis is not yet confirmed. It is not confirmed ectopic. It is pregnancy of unknown location. Yes, the patient is stable. Again, keep this in mind. Patient is stable. If it was ruptured ectopic, sir, it could be ruptured. No, sir, in ruptured ectopic, patient will come to you in shock. Yes, if it's a ruptured ectopic pregnancy, there will be shock. And then you don't repeat all this and directly resuscitate the patient and shift to OT and do a surgery. So ruptured ectopic, patient is in shock. Stable patient, this is a confusion, diagnosis not certain, repeat beta HCG after 48 hours and then the mystery will settle down. And 1000 level, what happens to the 1000 you have to check. Is it clear? So this is very important MCQ. Do not make a mistake in this. It's surely coming in the upcoming exam. Okay, yes, primary amenorrhea, breast well developed. So definitely again primary amenorrhea, one MCQ has to come. Okay, it's a short topic. Okay, absence of axillary pubic hair, lump fed in the region, and USG uterus is absent. So my dear student, first of all, the primary amenorrhea, we are supposed to remember the new definition. Is this clear to all of you? Please understand this. 14 and 16 is the old. 14-year-old and 16-year-old is the new, is the old definition. We have to follow the new definition. One year lesser, which is 13 years and 15 years. That if menarche is not yet attained by 13 years in absence of secondary sexual characters, or if secondary sexual characters are present, then by 15 years, if the menses have not yet started, you call it as primary amenorrhea. Now, I am going to give all of you a super hit mantra that, sir, if it is a primary amenorrhea and along with it, if it is absent uterus, in the whole of gynecology, my dear student, there are only two possibilities. Don't even look at option 3, option 4. Sir, either it is RMKH, Rokitansky, Mayer, Kushner, Hauser, or androgen insensitivity. Complete androgen insensitivity. The other name is testicular feminization syndrome. Okay, remember both the names, I'll tell you. And RMKH is nothing but another name for Mullerian agenesis. Is this understood to all of you? So Mullerian agenesis is another name for this RMKH syndrome. Okay, is it clear to all of you? So primary amenorrhea and absent uterus, only these two possibilities are. Don't even look at option 3, option 4. Why? Because the Turner syndrome uterus is present. How is the uterus in Turner syndrome? Can anybody tell me? Normal chotu chintu, yes, chintu uterus. Hypoplastic uterus, but uterus is present. And Kalman syndrome, also the uterus is present. Yahan pe absent uterus. So I have to think between only option number 1 and 2. Now please understand this. Yes, of course, karyotyping first of all. This is 46XX, this is 46XY. ये तो लड़का है. It's a by mistake. Actually it's a boy. Okay, wrongly assigned the sex of female at birth. Okay, so actually person is a boy. And testicular feminization. That means, sir, there is testes, but rest all features are feminine. Now please understand this. Breast is not a difference. Keep this in mind. So breast is well developed in both the cases. Here also plus, here also. Breast is well developed in both the cases. That is not a difference. What are we supposed to see? Yes, sir, we look at the hair. But hair where? Not this hair. Axillary and pubic hair. Why? Sir, even in females, the axillary and pubic hair is androgen dependent. So, sir, here when I look at this patient, axillary and pubic hair will be well developed, but in this column, axillary and pubic hair will be absent. To make the MCQ tough, they can give sparse. Okay, because androgen does not work. It is androgen insensitivity. And that, my dear student, is the answer. Okay, sir, when I have got absence of axillary and pubic hair, the answer is androgen insensitivity syndrome. Only one line difference. If this absence become presence, answer will be RMKH. Clap. So only one word difference can change. Absence of axillary primary amenorrhea, absent uterus, Presence of axillary pubic hair becomes RMKH. Absence of axillary pubic hair becomes androgen insensitivity. And can one more thing, very important, what are the gonads present in RMKH? Sir, in RMKH, the gonad present is ovary. They are perfectly normal ovary. And here, sir, the gonad present is testes, but descent of testes is androgen dependent, and therefore here androgen cannot act. Androgen cannot act. Testosterone cannot act, as I told you. Okay, so since the testosterone cannot act, but testosterone gets converted to estrogen, so therefore it's like a estrogenized male. Okay, ये person क्या है AIS, right? Since intrauterine life has only been exposed to estrogen and never exposed to testosterone, and therefore testes will remain undescended in the inguinal area, and that is one more clue. You will feel a lump felt in the inguinal region. Clap. What is this lump? So this lump is the testes, and please comment in the chat box, what will I do with the testes? Will I keep the testes, remove it? What should be done with the testes once you make the diagnosis, and why? Okay, so I repeat, this is primary amenorrhea. Keep the new definition in mind, and primary amenorrhea, absent uterus, only these two options you have to think. And because of absence of axillary pubic hair, the answer is androgen insensitivity syndrome. Is this understood to all of you? Yes. Moving on to the next very important, again my dear student, ये short topic है, trisomy 21 testing. Okay, all the tests we should know, double, triple, quadruple, everything. Okay, so 33-year-old patient, 12 weeks, at 12 weeks we do the dual marker test, shows high risk for Down syndrome. What is the next best step? Now, mistake which student make is, first of all, okay, oh my god, this is Down syndrome, and many will say that directly do MTP. Yes or no? Wrong. Why? Because we are not God. If I confirm it's a Down syndrome, there's no treatment for it. Of course, if it's Down syndrome, our job is to offer MTP and go for MTP. Of course, patient will choose. But please understand this, the concept in this MCQ is, okay, sir, the dual marker test is only a screening test. Is this understood to all of you? It is not a confirmatory test. So many students will feel that sir, dual marker test is abnormal, let me do a quadruple marker test. Again wrong. Why? Because sir, quadruple marker test is also a screening test only. Okay, because sir, when one screening test is abnormal, no point doing another screening test. Why? Because please understand this, okay, screening test never gives you a confirm answer. If you have seen the report, the screening test, whichever it is, okay, double marker, triple marker, quadruple, I'm writing double marker test, triple marker test, quadruple marker test, all the screening test only tells you that the risk is low risk or high risk, that your chance of having an abnormal baby, if it is low risk is indirectly normal, like nothing needs to be done further. Low risk matlab risk is very low, 1 in 1000, 1 in 10,000, like that. So low risk, nothing to be done further, nothing to be done. Okay, is it clear to all of you? Because it is like normal. But if the screening test is high risk for Down syndrome, yes, I need to first go and do a confirmatory test. And my dear student, confirmatory test in the whole world is only one, which is what? Karyotyping. Now again, how can I do the confirmatory test? Sir, two options. Tell me. One is chorionic villus sampling and second is amniocentesis. Please comment in the chat box when is which test done. Okay, so before that, just one more information. Dual marker test, what are the components of dual marker test? Yes sir, HCG and PAP-A. HCG and PAP-A. Okay, it's done around 11 to 13 weeks, so यहाँ पे 12 weeks. HCG is higher than normal and PAP-A is lesser than. PAP-A is pregnancy associated plasma protein A. PAP-A is lower than normal. Okay, so please understand this, that dual marker is showing high risk. Never directly go for MTP. Is it clear to all of you? MTP never directly. First, sir, I need to do again, no point doing a quadruple marker also screening test. What is the logic? Sir, whenever it is a screening test is showing high risk, I need to do a confirmatory testing. Okay, and can you tell me, sir, amnio is done after 15, 16, 18 weeks. Amnio generally done the second trimester at 16 to 18 weeks of gestation. Is this understood? So chorionic villus sampling can be done anytime after 10 completed weeks. Please comment in the chat box what can happen if I do early chorionic villus sampling. Suppose the chorionic villus sampling is done early, 7, 8, 9 weeks. What complication can happen? Therefore, we best do after 10 completed weeks, and chorionic villus sampling is done in the first trimester, preferably between 11 to 13 weeks of gestation, which, my dear student, is the answer over here, because we are how many weeks of gestation? So we are 12 weeks. So amnio cannot be done, and the answer is chorionic villus sampling to confirm. Is it clear to all of you? Yes. And if it is confirmed Down syndrome, then you can offer MTP to the patient. Is it clear? But never directly jump to the MTP. Suppose the same MCQ comes. Now one word change. Instead of this 12 weeks, I make it 16 weeks. If I say that the primigravida patient comes to you at 16 weeks of gestation, and instead of dual marker test, the quadruple marker test is high risk, then what do? Yes, sir. Then the answer is amniocentesis. Clap. So see how one digit change. I repeat, because at 16 weeks, I can't do chorionic villus sampling. So variation in the MCQ. Is it clear? Okay, sir, if instead of 12 weeks, 16 weeks is given in the question paper, and at 16 weeks, I do a triple or a quadruple marker test that is showing high risk, then I will go and do amniocentesis. Okay, so but here we are 12 weeks, so the answer is chorionic villus sampling to confirm the diagnosis, and then only proceed for the treatment. Is this understood to all of you? Yes. Very important IBQ. This has also been asked in the exam, and again they can add some extra information to this, like starting May, a patient is there in labor, 39 weeks, all that, and this kind of pattern is seen. Now this is a cardiotocography. Why cardiotocography? So these are the fetal heart rate. So that's the cardio part of it, and these are the uterine contractions. Okay, so this is called as toco. Same thing above. Okay, fetal heart rate, and this is the uterine contraction toco. So this is CTG, cardiotocography, tocotali. Okay, so here you can see like there's a relaxation, then one contraction, then one contraction. So okay, so during contraction the pressure rises. Okay, so here also the uterus is relaxed, then there's a contraction, and again uterus relaxed, there's a contraction will come like that. Is it clear to all of you? Now you have to observe the pattern. Please understand this. What is happening over here? First of all, you should know what each deceleration indicates. Now for early deceleration, my dear student, early deceleration, please remember mirror image. The word to be kept in mind is mirror image. That means, sir, if the fetal heart rate is dropping down, okay, heart rate is dropping down, that's a deceleration, and returning back to normal. And if it is exactly coinciding, if it's like a mirror image of the uterine contraction, that means all of you look on the board like this, something like this. Okay, I will explain to you in further detail. This, my dear student, is your early deceleration. When do we get it? Please comment. That means, what am I saying? Mirror image means, that means what? So contraction start, heart rate starts to go down. Contraction over, heart rate return back to normal. And the peak of the contraction will correspond with the lowest point. Lowest point is called as nadir. Okay, is it clear? So you can see over here. Clear, sir? Contraction start, heart rate starts to go down. Contraction over, heart rate return back to normal. And this peak of contraction and this the lowest point nadir are also facing are corresponding or are facing each other. That means it is exactly the mirror image. That is early deceleration. But is that pattern over here? No. Here what it is, sir? Acceleration and the contraction has already started, reached the peak, and almost also the contraction is over. Then the heart rate is going down, and see the recovery. The recovery is much after the contraction is over. So the contraction ended over here. The recovery is happening over here. contraction already peak has happened, and then the heart rate is going down and afterwards. Okay, so this is a late deceleration. Yes, you can again compare with this picture also. Both the pictures showing the same thing only. Okay, sir, the contraction is coming ahead. Contraction is before only, and then the heart rate goes down. Okay, so it is late. That means, sir, here if I show you, okay, sir, if I draw this like this and this like this, just to show you, then what is the heart rate like that? Yes, sir. Okay, sir, heart rate, baby heart rate goes down, goes down, goes down now, and then it return back to normal. So here, sir, already the contraction is over, and then the heart rate then is coming down, and the recovery is much after the contraction is already over, and iska peak and iska nadir are the nadir is afterwards. Okay, same thing. Okay, sir, well after the contraction has already started, and then the heart rate is going down, and then the recovery is taking place much after the contraction is over. That, my dear student, is a late deceleration, sign of fetal distress. We see it in uteroplacental insufficiency, UPI, uteroplacental insufficiency, or fetal distress, or a fetal hypoxia. All mean the same thing. Late deceleration, very dangerous. Is it clear to all of you? So keep this picture in mind, very important. Again, a super MCQ, even a one-line MCQ can be tougher based on color Doppler. Fetal anemia can be diagnosed with which Doppler? Okay, so everything I will tell you, please understand this. Uterine artery Doppler is for what? Can anybody tell me? Sir, uterine artery Doppler is for prediction. Prediction of what? Yes, sir, uterine artery Doppler, if I see a notching in the uterine artery, persistence of diastolic notch at around 18-20 weeks, okay, after 20 weeks, or increase in pulsatility index at around 11-12 weeks. It is a prediction. Okay, sir, mother can develop preeclampsia and baby can develop IUGR. Is it clear to all of you? Okay. Umbilical artery Doppler and ductus venosus are again very important for IUGR. Umbilical artery Doppler may, if the S by D ratio, D is becoming less, and then you get absent diastolic flow, reversal of diastolic flow, that is an indication for immediate delivery. So umbilical artery Doppler is very important for IUGR ka management. IUGR ka management. And the umbilical artery Doppler will decide when to deliver, and how to deliver. Okay, when and how to deliver in IUGR cases is decided by the umbilical artery Doppler. And ductus venosus is again same thing for IUGR management. Ductus venosus, if you see reversal of flow and pulsatility, again it's the end, last thing to get abnormal. Okay, so umbilical flow will become abnormal. And when there's reversal of flow in umbilical artery, at that time also ductus venosus reversal, it is indicating a impending IUFD. You need to immediately get the baby out. Okay, if you see a pulsatile flow, okay, so ductus venosus may, if you see reversal, it is a sign of impending IUFD. Is this understood to all of you? Fetal anemia, sir, we can get it in cases of RH isoimmunization. What we use is a middle cerebral artery Doppler. Okay, middle cerebral artery is also used in IUGR or brain sparing effect. That's a separate MCQ. But middle cerebral artery, how? Please understand this. What we look at is something called as peak systolic velocity in the MCA, middle cerebral artery. Simple logic. Now, when there is fetal hemolysis, the blood is thin. So, if it's a thin blood, will it go slowly or it will go very fast? Common sense. Yes, if the blood is thin, if the blood is hemolyzed, blood will go fast. So peak systolic velocity, what happens? Sir, it increases. So if the peak systolic velocity is rising in MCA, and specifically if it is more than 1.5 MOM, virgin MCQ, Thoko Tali, surely coming in the upcoming exam. If it's more than 1.5 MOM, what is MOM? It's a PSM terminology, multiples of median. Okay, MOM kya hai? Multiples of median. That means indirectly normal. MOM is like a normal. So if it's more than 1.5 times the normal, then it is called, then it is indicating of fetal anemia. Is it clear to all of you? So remember, for diagnosis of fetal anemia, this is a non-invasive best method, middle cerebral artery Doppler. And usme what do we check? Sir, we check for peak systolic velocity. We check for peak systolic velocity, and if it is more than 1.5 times MOM, then it is indicating of fetal anemia, and we study this in the middle cerebral artery. Is this understood to all of you? So it's a very difficult and very important MCQ. Now again, a clinical case, 37 weeks, brought to emergency. So see, all these are emergency, okay? Pain in abdomen, hypotension. So the shoulder dystocia में hypotension generally नहीं होता है. Clear? So one option ruled out by reading the first line only. Abruption can have hypotension, yes. Placenta previa after lot of bleeding can have hypotension. Rupture uterus can have hypotension. Now, is there any bleeding generally? No, sir. In placenta previa, what it will be? Painless bleeding. Painless bleeding per vaginum, painless bleeding in the third trimester. Uterus is generally relaxed. Uterus is relaxed. Is this understood to all of you? In placenta previa. Again, is there any kind of picture? No. Okay. Yes. Abruption may also there should be bleeding in revealed variety. Concealed abruption, so there may not be any bleeding. Abruption में क्या होता है, my dear students? Uterus, yes, can be tender, but it is a tonically contracted uterus. Tonically contracted uterus. Patient will be in shock. Yes, here also the patient is in shock, and baby could be dead. So we have to go between A and B. Okay, but now the clincher is on examination, fetal parts felt superficial. That, my dear student, is the clue. Why? Because, sir, when the uterus, so there's a uterus, there's a baby inside the uterus, and following a prolonged labor, obstructed labor, or excessive misoprostol or oxytocin has been used, then, sir, there would be a rupture uterus, and the baby, what happens is, in rupture uterus, my dear student, the uterus will rupture, the uterus stops contracting, and the baby comes very superficial, because baby comes outside the uterus, isn't it? Otherwise baby is inside the uterus. So baby bahar aa jata hai. So baby is outside the uterus. Baby is outside the uterus, and that is the reason why we palpate it very easily. Okay, so easily palpable, or fetal parts superficially palpable. That means, sir, you are finding it just below the skin, and the abdomen, of course, just below the rectus sheath. Okay, so just below the rectus sheath, okay, just in the abdomen, we are palpating the fetal parts very superficial or easily. That, my dear student, is a classical sign of rupture uterus, which is the answer over here. Abruption may generally it could be associated with hypertension, lot of bleeding, patient in shock, but usme of course the baby is inside the uterus. IUFD can happen. Uterus will be tonically contracted uterus. Baby could be alive or dead. Okay, fetal heart's not heard, of course, in case of IUFD in rupture uterus. So this is rupture uterus. This is a rupture uterus, which would of course lead to IUFD, and that is the reason why the fetal heart sounds are not heard. Is it clear to all of you? Okay, so please keep this in mind, rupture uterus. And also one more thing which is very classical, keep in mind, is that when the baby is coming down, okay, in labor, baby is coming down, and suddenly there is rupture uterus, the baby moves upwards, correct? The baby goes outside. So there is loss of station, very important word, PG level. You answer this in your loss of station means what? Suddenly, so like the baby is coming down. Okay, so +1, +2, and suddenly rupture uterus, baby goes up. Ulta, baby goes back up, and is loss of station. That means baby recedes up and baby comes out of the uterus into the abdominal cavity, because baby is outside the uterus in the abdomen. Okay, so loss of station during labor is also a very important clue. Please keep this in mind during the MCQ examination. Clap. Okay, now again, 26 years old lady, present with history of missed periods, unprotected sex during the fertile window, anxious to confirm whether she's pregnant or not at the earliest possible. Earliest diagnosis of pregnancy is by. So again, over here, my dear student, all this is extra information which is just given to waste your time. The question starts directly that which among the following, this is one-liner MCQ. This one-liner MCQ has been made into clinical case by adding extra information time pass. Is it clear to all of you? As I said, the question actually starts from here. Earliest diagnosis of pregnancy is by, and many students directly they will say urine pregnancy test. They will directly say, okay sir, the earliest diagnosis of pregnancy is by urine pregnancy test. Wrong. Clean bold. Or sonography. Wrong. Why? Because sir, the UPT, urine pregnancy test, what we do, okay, I'm sure you must have seen a kit. That kit is there, and in that you put 2 drops of urine, 2 बूंद खुशी के, 2 बूंद जवानी के हम डालते हैं, and then कभी खुशी कभी गम. Why कभी खुशी कभी गम? Because sir, if it's a planned pregnancy, happy. If it's an unplanned pregnancy, tensed up. Okay, gum. So there could be then 1 line or then 2 line, and you know. But sir, this urine pregnancy test is detecting what? Urinary HCG. This is detecting urinary HCG. Okay, so it is for urinary HCG, and that is positive only after missed periods. Please understand this. Suppose it's a 28-day cycle for the patient. Example, 1st August, 28 August. And then the ovulation is taking place on the 14th day, and then the intercourse or the fertilization is at the same time. Now please tell me, the embryo is traveling. When does the implantation take place? One more MCQ. Sir, implantation takes place 6th day. Yes, it's a window, 6 to 8, the 6th day following fertilization. So roughly, sir, day 20 to day 21 is the implantation. So the urine test, my dear student, will only be positive over here. The UPT is positive only after missed periods. Only after the lady misses the periods, then the urine test is positive. Here I want earliest. That means sir, 1st August hai, 28 August hai. Here sir, 2-3 days she has missed. She didn't get her periods over here, so she has missed her periods, and then the UPT is positive. Sonography still later. Please comment what is the first structure which I see on sonography, and when do we see it? So sonography generally 1, 2, 3. Generally over here, few days after missing the period, we see something on sonography. Okay, so the earliest diagnosis, my dear student, is by serum beta HCG, the blood test. The blood test, the technology is so advanced, my dear student, कि on 21st day implantation होता है, 22nd, 23rd day, here itself the serum beta HCG is positive. The serum beta HCG can be detected in the blood 24 to 48 hours after implantation, which is the answer over here, because the serum beta HCG is positive even before the missed periods. Is it clear to all of you? Even before the missed periods, it is positive if the lady is pregnant. That means over here, sir, all these places, she has not even missed her periods. All these places, which is all these days, 23, 24, the serum beta HCG is positive, then the patient is pregnant. Is this understood to all of you? But now just one word I change. Clap if you appreciate this. Earliest diagnosis of pregnancy is by serum beta HCG. But one word if I change, and if I make this earliest diagnosis of live pregnancy, one word live, L-I-V-E, live, one extra word, 4 letters extra added to the MCQ, the answer will change. Why? Yes, sir, when it's a live pregnancy, so urine test, HCG, sir, serum beta HCG only tells me pregnancy. It only tells me pregnancy. When it is a live, for me to check live pregnancy, what do we check? Yes, sir, we have to check the fetal कार्डियक एक्टिविटी, बेबी का हार्ट बीट, ठक 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 ठक, टाइगर जिंदा है, पठान जिंदा है. ओके, सो टू कंफर्म दैट द बेबी इज लाइव, आई हैव टू डू अ ट्रांसवेजाइनल सोनोग्राफी to pick up the fetal cardiac activity, which can pick up heartbeat of baby around 5.5 weeks or 6 weeks, around 5 weeks, 5 days or 6 weeks. Is it clear to all of you? So if one extra word live MCQ aa gaya, then your answer will become transvaginal sonography. Is this understood to all of you? So making the question back to the actual question as it was, earliest diagnosis of pregnancy is by serum beta HCG. Transvaginal is to earliest diagnosis of live pregnancy. Is this understood? Because sir, for live pregnancy I need to check the fetal cardiac activity. Crystal clear to all of you? Yes. The next MCQ. Yes. Now this is a video based question. So first we will see the video. And then you tell me what exactly is happening. So you can see over here some nick is being made and then sees the blood starts coming out and then you can see a old clotted just artery for further, and then we can see that what is coming out, we is dilating it, and yes, all the altered blood, can you see slightly the altered blood is coming out. So nick made and altered blood is coming out. What is this? Of course they will give you a history. That this is a 15-year-old or a 14-year-old with a primary amenorrhea along with cyclical abdominal pain, and when this surgery is done, and the nick is made, you can see the video one more time. And you can see that sir, we are making a nick, and once we play the nick, and you can see after making a nick, the old clotted blood is all altered blood, red brownish color blood is coming out. Yes, anybody? So what is this? Yes, perfectly correct, my dear student. Primary amenorrhea, cyclical abdominal pain. This is your imperforate hymen, and this is cryptomenorrhea. Cryptomenorrhea matlab ke hidden, crypto matlab hidden, and imperfect. Yes, normally sir, we make a cruciate incision. Here just one line was made instead of making a up and across. But when you make a cruciate incision, there's a tense bulging hymen. Bluish purplish tense bulging hymen is there, and on top of it, when you make a nick over here, you will see the blood coming out. Cruciate incision. Why a cruciate incision is made? Because sir, when you make a cruciate incision, it opens up like this and you can see the all blood coming out. So this, now what the question is directly kya hai? Directly student think of imperforate hymen and give the answer. Wrong. Please read. What is the long-term complication of this condition? They have not asked you the diagnosis. If the diagnosis asked, of course imperforate hymen is the diagnosis. Okay. What is the long-term complication of this condition? Yes sir. What happens sir? Because the blood is getting collected inside the uterus. Okay. Uterus, cervix, vagina, and there is a imperforate hymen. So whenever sir the menarche will start, the blood will come out, but that's why that gives us cyclical abdominal pain, but the blood is not coming out of the, it's staying only inside the vagina, giving rise to hematocolpos, and that can also give rise to pressing the bladder urinary retention episode, and then the blood further gets collected inside the uterus, giving rise to hematometra. Yes, hematometra. Therefore, they can also have a suprapubic bulb. And what can happen, my dear student? Long-term complication. Yes, the backflow theory, retrograde menstruation. So the blood goes backflow, and therefore these patients have got long-term risk of endometriosis. Whose theory? Please comment. Whose theory of retrograde menstruation? Kiska naam se theory hai? So the long-term complication of this condition is not a dermoid cyst. It's not a ectopic pregnancy. It is endometriosis. Any long-term complication of this condition matlab ke cryptomenorrhea. Whenever it is a long-standing cryptomenorrhea, or in this case imperforate hymen is our diagnosis of the video, long-term complication is endometriosis. Is this understood? Because the blood is getting collected inside the vagina, giving rise to hematocolpos, tense bulging hymen, and then we make a cut and all the blood comes. Same thing was shown in the video. Okay, so don't be afraid of video based question. It's just a way of, it's an extension of IBQ. If you know your theory, video based question will also be very easy to answer. Is this understood to all of you? Long-term complication is endometriosis. And look at this beautiful colored notes, my dear students. Once you have seen my videos, exactly in just 2 hours hours. You can go through the entire notes. There's also notes read along video with it. And this, my dear student, this is going to be life changing. It's going to be the game changer. It is tremendously going to boost up your rank. Okay, if with your current knowledge you are getting 10, 11, 12, 13 MCQs correct, just attend this 6 hours. Just attend this 6 hours course. It's ultra fast. Okay, OBG booster, just 6 hours, 3 sessions of 2 hours each, and your OBGY rank score will jump up from 12, 13 to 17, 18, 19. 5 to 6 marks more, 5 to 6 MCQs more you can get just by attending this 6 hours course only in 333. It's an early bird offer till 10th of August. If you enroll, you're going to get in 333. Then the prices will go up and the classes will start from 13th of August. Okay, 13th, 14th, 15th. 3 days. 13th August, 2 hour session, 14th August, 15th August. My dear student, whichever source OBGY you have studied from, don't worry. If this, like this session, it will be exactly MCQ based revision. It's a MCQ based, where first session we will be discussing all the image based and video based MCQ, including all the video based. Then we'll also be discussing all the clinical MCQs, and then the most expected MCQs, along with it beautiful notes and notes read along video, and all the recent advances also you are going to get just in 333 rupees. So as I said, whichever source OBGY studied previously, does not matter. Just come and attend this, and of course the recordings will be available till the NEET PG. All recordings. So it's not that only those 3 days. Recordings will be available till the date of the NEET PG examination. So download the OGGuru app from this link and this code. Get in touch with me on phone and WhatsApp, and just in 333 rupees, my dear student, attend 3 sessions of 2 hours each, 6 hours live, and then recordings also. You can see live sessions will have MCQ discussion, as I said, clinical case, image based, video based, and most expected MCQs. And your OBGY will become your highest scoring subject in the upcoming NEET PG. When you will walk out, you will message me and tell me, is this understood? All this you can read, my dear students, for you to read, sir. All questions, I followed your lectures. This OBGY cake for me. All questions directly from your videos, sir. All got all correct in OBGY. Same thing will happen with you. Question also the same way as per your format. That I took the revision hours and absolutely helpful. Okay, so all this thing will happen with you also, my dear student. And do not forget to follow us on Insta, share this video with all your friends and colleagues, hype this video, subscribe to the YouTube channel also. The PDF of this will be available on Telegram, and I'm hoping to see all of you live on. Do not miss out this opportunity. Final chance before the NEET PG, 13th, 14th, 15th August. So 13th August, we'll be seeing you live, and we are going to have a lot of fun in solving the MCQs and all the expected MCQs we're going to discuss. Okay, feel free to get in touch with me on phone and WhatsApp on this number. And here's wishing you all the best for the upcoming NEET PG examination. Best of luck.